Okay, so the next probably very important special population, since that deals with almost half of our patients that are afflicted with IBD, is talking about how to optimize the management of IBD during pregnancy. So why does it matter? Why is this such an important topic? And why are we going to spend time in the next 15, 20 minutes or so highlighting the pregnancy management? So as you can see, that the peak age of onset of IBD overlaps essentially during the years of childbearing years, so for our women diagnosed with IBD. And so sometime in this 20 to 30 age group is where we see the peak of the epidemiology of IBD, overlapping with, there's about 800,000 women with IBD. So this is a very big proportion of patients that we are managing. And can I get pregnant or will I get pregnant remains a very important discussion point, even dating back to when I see the moms, when I'm talking to them about their 16-year-old daughter, their biggest question to me is, how will this disease impact their fertility and will the medications be safe? So this is on everybody's mind, no matter really what age they present. And one thing to remember is that lack of knowledge is associated with most of the impact of pregnancy on our women with IBD. That voluntary childlessness is the #1 reason for fertility issues, and that is driven by lack of knowledge about the safety of these medications during pregnancy and also any knowledge about how this disease will impact pregnancy. And so just actually a slight change in the Crohn's and colitis pregnancy knowledge score actually reduces the voluntary childlessness rate significantly. So one of the things we can all do and walk out of here is be able to educate our women about the idea, about knowledge, about how this disease impacts fertility, and I'll walk you through sort of what we do know and highlight some of the things we don't know. The good news is we know a lot more than we don't. In terms of one of the key misconceptions or misperceptions is that the medications are harmful to my baby. I can put up with a little bit of bloody diarrhea as long as my child doesn't get exposed to these medications. Again, it's this idea that you need to protect the baby, and this idea that people are missing, that if the mom is good, the baby will be good. And I think one of the most important messages that we often sell short to our patients, because we know they're nervous and they want to save their baby from exposure to our meds, is we are not talking to them enough about the negative impact of inflammation on every single aspect of a woman's fertility, staying pregnant, preeclampsia, low birth weight, small for gestational age, postpartum flares, and so all of this is tied to controlling inflammation. So one of the things we need to change completely our dialogue with these moms is letting them know that you are the priority actually, and that your control of your disease will help improve the outcomes of your baby. And it's completely 180 to what you walked in the door to talk about. And I think if we could sort of switch the whole frame shift, we'll really make a difference in these women's lives. What do we know? So the only thing so far that has ever been shown to impact fertility has nothing to do with having IBD. It's called age. So the #1 predictor of infertility in all women, whether you have IBD or not, is age above 35. We see a significant drop in fertility whether you have IBD or not. And so I'll walk you through what that means to patients with J pouches in just a minute. But I really want you to see the drop from 34 down to 35, even in the blue histogram bar, which is non-IBD patients. So when a woman walks into my clinic who's 29 and who's undergone a J pouch, for example, my conversation about fertility risk is very different than a 37-year-old who has had a J pouch. And my emergency to send them to a fertility specialist is very different between a 29-year-old and a 37-year-old, because it all comes down to age. So it's really important that we stress the idea to our patients that age still remains the biggest factor of infertility, regardless of IBD status. What about a J pouch patient? Now, everybody is basing our communication about the risk of J pouches based on open surgeries for the last 40 years. No data is available on the true risk of infertility in the era of laparoscopic J pouches. This is very important when I distinguish the risk of fertility. What we do know is if you take women of childbearing and who are not on contraception, and you use the general population, let's say as a adjusted fertility rate ratio of 1, let's just state, that you have a 57% drop in fertility compared to the general population if you've undergone a J pouch. You're probably like, wow, that's a huge difference in infertility. But I want you to recognize again, that this was mostly in the face of open J pouches, which means not in the area of the laparoscope. We know that laparoscopic surgery reduces the rates of adhesions that are causing obstruction in the fallopian tubes for them to become obliterated, so obviously conception cannot happen naturally when you have a plumbing issue. This is all a plumbing issue. The uterus is just fine. There's a lot of myths about the fact that if I've had a J pouch, I actually can't even get pregnant. Whether it's natural or IVF, there's just a myth across the board that people have translated, I can't have a baby if I've had a colectomy. That is really a big problem for us because they come in the door and say, oh, I thought I could never get pregnant. And so you have to start unraveling where the myths exist. But if you could somehow say, let's take away the risk of surgery, let's take away the risk of medications, and let's focus on what really matters is that if you do not have controlled disease, your baby will have altered outcomes. And that is why I start off my preconception clinic. I look at their list. They all want to know about safety of medications. I said, I'll get to that in a minute. Let me explain the safety of your disease. And then by the time they walk out of the clinic, they're like, when do I start my medication? You know, how do I get inflammation under control? I've missed my window of, there's a lot of hysteria around. I must have missed my window of opportunity. And so I need help in getting pregnant. And a lot of that is just good disease control. So what this slide actually shows you, it just shows you when you see in Crohn's, when you go down the list of adverse outcomes, I'm sorry, this is off center, and it shows you that preterm birth, flaring, low birth weight, which is probably one of the biggest outcomes of what moms want to know is what is the two things that are most important if I had IBD. One of them is low birth weight and the other one is preterm delivery. That's sort of the two biggest issues we see, and guess what? Both of those are driven by inflammation. So we could actually prevent a lot of these outcomes from happening if we would just focus on managing the mom. And that's why the high-risk OBs are so helpful to us, is because they tell the moms it's okay to focus on you, and the general OBs are saying, let's focus on the baby. And that is why women are stopping their medications before they even come to see you to declare themselves pregnant. And they're not asking you whether they should stop their meds before they get pregnant. So one of the things we need to do is proactively make the statement up front in those women where it's appropriate, just to let you know, please call me before you stop any of your medications. Your OBs are generally going to tell you to stop your medication. So be proactive about that so that they know they can pick up the phone to call you. This was such a big problem that we created through the AGA published this year, the preconception pregnancy sort of clinical care pathway. We called it a CCP and not a guideline because there's really no data to really give you a guidance, right? There's very limited accurate data to actually give you a specific guideline as to a patient. So what we did is we mapped out sort of a care pathway to better understand how to manage these women through the and a Parenthood Project working group with the website. So I'll walk you through some of the stuff we declared in this paper. So one thing that I could tell you, that the number one thing that the mom is walking into your clinic wanting to know is, will my medications affect my baby's development? Meaning, will they develop a congenital anomaly or a malformation because of the meds that I am taking, and will I harm my baby? So what you need to tell them is, having IBD alone does not increase the risk of congenital malformation. And other than tofacitinib, and I'm only saying that because we don't have a lot of data, other than tofacitinib and methotrexate and thalidomide, every medication you will be using to manage IBD will not cause a congenital malformation. The congenital anomaly rate for thiopurines, for 5-ASAs, for steroids, for biologics is somewhere between 3 and 4%, which is the same rate as the general population. So there is no increased risk of congenital malformations. Now this slide unfortunately really speaks to what I said about stopping therapy. We studied whether or not there are certain disciplines that are stopping drugs more often than others. The good news is that gastroenterology is the lowest group of physicians that are telling moms to stop their therapies in anticipation of pregnancy. Obviously, the primary care and the general OBs are not helping the cause. Dermatologists are underestimating the risk of inflammation actually on baby outcomes, and there's a subfertility, meaning women with active psoriasis have a harder time getting pregnant. And rheumatology, it's sort of split, and they're using meds mostly as an as-needed basis. Again, we're doing patients a disservice if we're underestimating the risk of systemic inflammation on the baby. Why is there such a pain point around stopping your therapies? Most of it came out after we showed that over 10 years ago that biologics do cross the placenta in the third trimester, and even hinted that there may be a preferential crossing to the baby instead of staying in the mom's serum, especially of infliximab. And you could see here that this graph sort of shows you the uptake of placental transfer, which matches the transfer of antibodies that a mom is giving the baby for immunity. The baby's placenta cannot differentiate IgG subclass 1 for hepatitis, for example, any different than what infliximab looks like or what adalimumab looks like or any of these IgG subclass 1. So the placenta can't differentiate. It has an Fc receptor. The Fc portion binds and it crosses. And the reason why certolizumab doesn't cross is because it doesn't have an Fc receptor. So that's sort of the concept of how we're differentiating which meds do cross the placenta and those that do not. We used to have a battle. If you come to DDW, you would see the Europeans would say to stop your biologic, particularly TNFs, at 22 weeks of gestation. Don't worry, the moms will be fine for another 4.5 months, versus those in America, we were saying, no, you need to keep these moms on therapy at least until week 32. So we created a bit of a scandal because we were back and forth giving misinformation per se. We were sort of conflicting information, and people were getting frustrated. So thankfully, after I'll show you the next slide, we've all come to the agreement that we're not stopping we're not stopping the TNFs in moms before week 22, and if anything, we're proposing you can continue all the way straight through. But this is what was happening. This was published in AJG last year, showing you that women are presenting in the first trimester, they're on their TNF, about 82% of women are still on their drug. That gets about half in the second trimester, and forget about it in the third trimester. So this was the European teaching, and people were following through on stopping these drugs early. But what they did show, and focus here on the table, is that when you stop moms from getting TNF after week 24, I know it won't be a surprise to anyone in the room to tell you that moms flare. Shocking. They need it every 4 weeks, and yet you're eliminating, for example, the one drug that's keeping them in remission during pregnancy. So we also showed that it's safe in babies, and this big study also showed that it's safe in babies. And to be honest, even though the first line says that moms may have more increased infection rates, I can tell you we've just looked at thousands of women that were exposed to TNF. Even at the time of delivery, we were giving TNF, there was no increased risk of infections. So this, I don't know what kind of infections they were quoting in hospital. We have not seen any wound infections, any increased risk of pneumonias, and no vaginal tear, risk of infection or wound healing, both C-section or vaginal tears. This was published in JCC last year, showing you sort of what happens to drug concentrations in moms, and what it does show you is that indeed, I will be transparent, that infliximab levels do rise in the cord blood as the third trimester progresses towards delivery with infliximab, but adalimumab, it only starts to increase towards the very end. So it's been shown now by the group in Calgary and now the group from the Netherlands, suggesting that adalimumab should not be halted at all during gestation, and infliximab, if you want to stop it sometime, one, you don't have to. That's one point. Second is, if the mom says, look, I know you tell me it's fine, but I'd like to really minimize exposure, when's the last dose I should get before delivery? anywhere between week 30 and 32. If they're on every 8 weeks, that's perfect. Right after delivery, they get their next infusion. So anything that's Q8, it's a little bit easier to do the math, and it's shown that if you give the baby their last infusion closer to week 30, there are indeed lower cord blood levels. To be completely honest with you, there is a time-dependent phenomena with cord blood. So I think if you had to come up with a summary, you'd say, I understand I could treat straight through and I need to treat the mom first. That's the first principle. Second principle, the mom wants to negotiate. She understands you think you know the literature. I'm talking to myself right now, is what typically is happening. And then I will say to them that let's have a negotiation. I'm going to give you your last infusion. I'm going to check a drug level to make sure your drug level is up at the 8-week mark. Therefore, I know I can get you through another 8 weeks without having a flare and a huge drop in drug concentration. That's my approach to the Q8ers. Those that are on every Q4, Q2, whatever you need to do, keep that mom well. And I'll show you some data as to why keeping the baby well in the 3rd trimester is indeed important. One thing is we showed that even if we're paranoid about the level of cord blood drug levels, there has not been any association between the height of the cord blood biologic level and infection in babies born to moms on these drugs. So the good news is that even having a drug level that's higher in the cord blood did not impact the baby's rates of infection. And this is an important conversation I have with my moms as well. This week 30 concept, week 30, week 32, comes from a paper that was published in Gastro in 2016, which actually looked at the correlation of when I last gave the mom her last infusion and the cord blood concentrations. And if you gave the last infusion right before week 30, to be fair, that was the one that had the lowest cord blood concentrations. So what I've started to do is help the moms feel better. I will get a drug level in the late 20s at the time of their infusion. If their level's very high and they want to negotiate a 10-week hiatus, I am giving them a 10-week hiatus. You need to negotiate with these moms. You have to understand the anxiety and the pressure that comes with being on these therapies and everyone telling them but you that they should stop their drugs. This is a very emotional discussion. So you have to be open to sort of give them the data and then say, your disease merits, you need this more often. I'm going to continue this drug through the 3rd trimester. I have a woman who's 29. She's an African-American woman. She has developed high blood pressure, gestational diabetes, and she's on adalimumab. Her levels are low. She's barely hanging on. I'm not stopping the drug. Right? I am continuing her on it because preeclampsia is a very big risk factor for these women. And we are seeing not only an increased rate of preeclampsia because advanced maternal age is one of the biggest risk factors for preeclampsia, but so is immune diseases. So if you have women who are getting pregnant later because they've been sick with IBD and you also have an immune disease that has potentially an inflammatory underlying inflammation that's not managed, the risk of preeclampsia is exponentially increased in your women. We are giving baby aspirin before week 16 in any woman who's at risk for preeclampsia. The American Society of OB came out with a list: African American women, advanced maternal age at first baby, and immune diseases. It's baby aspirin, it's 81 milligrams. You showed that NSAIDs are not a big deal even, and imagine 81 milligrams. So this could be the difference between someone developing severe preeclampsia or not. So talk to your high-risk OBs, and this is an important addition to the literature. This is just showing you sort of that moms will say, if my baby is exposed to these drugs in pregnancy, I tell them about the ratio of mine as a mom and if it was my baby. I will tell you that infliximab is the highest drug levels in the cord to any of our other biologics. That means there's preferential crossing of infliximab across the cord blood, in that it's a ratio of 2.5 times more infliximab in the cord blood of a baby than the mom at the same time that the blood was drawn. And you could see 1.4 for ADA, 1.4 for ustekinumab, and the interesting thing about vedolizumab, it's a reverse. It's 0.7, which means there's more in the mom than there is in the baby. So these are important things for us to start, and certolizumab obviously 0 because it doesn't cross. Pregnancy data with vedolizumab, just showing you that we don't have as much as we do with the TNFs, but so far no increased risk of spontaneous abortion, no increased risk of congenital malformations. You can continue the drug during pregnancy. Ustekinumab, again, we don't have a huge boatload of data, but what we do have so far, and from the psoriasis literature and psoriatic arthritis literature, there does not appear to be a safety issue. And one thing to remember, the only drug that has ever been tested in a placenta that resembles even closely to the human is ustekinumab. They used the primate placenta. All our other biologics used mice, which is not even close to a human placenta. So to be honest, we have the most animal tox data with this drug. We don't have as much safety data in our IBD patients, but we have with animal tox. TOFA is up for debate. I think there's a lot of discussion around whether or not, you saw Miguel said, we've been looking for patients who got TOFA in the first trimester, and we haven't found any. In our piano registry, we've had a few second and third trimester groups. We have not been able to find the first trimester exposure. I think people are nervous, and that's okay. But contact either me or Uma if you do want to ask some questions about it, because we do have a lot of data in our heads from the clinical trial that we've published on, and this is the paper from IBD in 2018. In terms of vaccination responses, your babies are good. They can respond well to the vaccines, regardless of what they were exposed to during pregnancy, so never hold back the vaccine. The only vaccine we do hold in all babies, except those exposed to certolizumab, is the rotavirus vaccine. It is a live vaccine, must be administered between week 8 and 15. Therefore, we're saying no live vaccines before the age of 6 months. Therefore, no rota in the current babies that are exposed to our biologic therapies right now. Just to tell you, vaccine doesn't prevent rota, it just lowers the severity of diarrhea. Again, not necessarily a major top of our list of our problems with our babies born to moms with IBD. And the one reason why we're becoming a little bit more obsessed about controlling inflammation, there is new data to suggest that babies that were exposed to a stressful environment, which includes TNF exposure, actually had higher risk of cognitive delay and behavioral outcomes, meaning more anxiety in kids who were exposed to inflammation in the third trimester. So any mom who's fighting you about stopping drugs in the third trimester and she's actively inflamed, please let her know that there's a lot of research being done to show. I'm not saying babies are smarter because they got exposed to our biologics, but I can tell you that babies don't do as well if they're in a stressful third trimester exposure to inflammation. Breast milk, no issues. Even if the drug gets in the breast milk, it's too big a molecule to actually go across the digestive tract. My Bible is LactMed. It is an app that everyone should have on their phone. It gives you, as of yesterday, update on drug concentrations and safety of all of our drugs. It's very important, and that is what I show my moms who are worried about breastfeeding. Monitoring, CRP and SED rate will rise during pregnancy, especially SED rate. So do not be fooled that your patient is flaring because their SED rate is elevated. They also showed that Calpro, if it's elevated, it's not because they're pregnant. There will be some inflammation. When to pursue endoscopy and what's the safest? Try not to investigate any of these moms if they don't have to be, but if you do, you can do a flex sig when possible, unsedated, unprepped in any trimester. Always take your MFM or your maternal fetal medicine expertise with you. Don't go solo. This is not something you should manage on your own. They are there to help you feel confident about what workup you need. Delivery, the only absolute contraindication to vaginal delivery is active perianal disease, active fistulizing disease. Then you get into a very heated discussion with your OBs about what do you do in moms who've undergone a J-pouch, because they have one shot at continence here. And if they have a grade 3 or 4 tear, and it makes it very complicated to heal, which means they tear into the sphincters, they can have permanent incontinence because of pelvic floor damage. Have a very, very informed discussion with your moms who've undergone a J-pouch. Don't forget about DVT prophylaxis. IBD women have a higher rate of venothrombotic embolism, and the risk in IBD goes on as you head through pregnancy. Don't forget for DVT prophylaxis, and it's a 3-fold increased rate of venous thromboembolic events in IBD. How can we guide our patients? We know that patients want to know how safe are my meds and how does my disease impact my baby. So the key message is that your disease itself and control of inflammation is what will have the most impact on the outcome. The safety of the meds I am using right now, prescribing for you, will help you maintain that goal and improve the outcome. So poor knowledge leads to voluntary childlessness. Post-IPA is associated with infertility. Decide on the timing of your biologics, but it has to be based on the patient itself. If mom flares, treat her. No live virus for the first 6 months, which means the ROTA, as I mentioned, with the exception of certolizumab. All our meds essentially that we're using are safe during pregnancy and breastfeeding, except the ones that I mentioned, and control of inflammation is king, and you can send them to our website, which is the IBD Parenthood Project. So thank you so much for your attention.